Hello everyone, thank you for joining me for this clinical case presentation. Our patient is LC. She is a 32-year-old female with complex GI and infectious diseases. A little bit more about LC. She is an archaeologist. She is a strict vegan. She does not smoke or drink. She gets daily exercise. Her marital status is single. And she was recently on assignment in the Yucatan Peninsula in Mexico. She doesn't know a lot about her family medical history, but there is a possibility that there was rheumatoid arthritis on her maternal side. LC's chief complaint upon admittance was headaches, cough, diarrhea, fever, night sweats, lower extremity rash, general malaise, and a 3-month history of worsening epigastric pain, abdominal distension, poor appetite, and a 16-pound weight loss. Upon admittance, the bed scale measured her as 118 pounds. Now, this is 88% of her usual body weight, which is 134.5 pounds, and only 82% of her ideal body weight, which using the Humwee formula is 144 pounds. LC's relevant medical history includes Crohn's disease, diagnosed in her early 20s, that caused a prior ileal resection. She also has hypothyroidism, vitamin D and B12 deficiency, pancreatitis from an acute trauma, and insomnia, and a number of other smaller injuries from her life as a thrill-seeking adventurer. Upon admittance, she was given 3 primary diagnoses. The first was hantavirus pulmonary syndrome. This is a pulmonary, meaning of the lungs, disease, which restricts blood flow by causing a buildup of fluid in the alveoli or air sacs of the lungs. It causes hypoxia or oxygen deprivation of tissues, as well as hypotension, which is severe low blood pressure, which also causes fatigue, which was one of LC's presenting symptoms. Hantavirus also affects the kidneys, which was compounded on by her history of acute trauma-induced pancreatitis. LC's second primary diagnosis was coccidioidomycosis, or valley fever. Valley fever is a fungal infection caused by breathing in certain fungal spores. Those spores begin to populate endospores within the lungs, triggering an inflammatory immune response. Often, this infection can be resolved on its own, but this was not the case with LC because of her multiple infectious diseases and her severe catabolic state. LC's third primary diagnosis was short bowel obstruction caused by a pretty severe Ascaris infestation. This had caused a section of her small bowel to become necrotic. LC was extra susceptible to this happening due to the hantavirus-induced hypoxia. This Ascaris bezoar was moved into the necrotic section of her small bowel and removed. This was her entire duodenum, as well as 100 centimeters of proximal jejunum. This has extremely significant implications for LC's nutrition moving forward, which we will discuss in just a moment. However, immediately following her emergency laparotomy, LC developed disseminated intravascular coagulation. Now, LC's hypermetabolic state had caused her to develop thrombocytopenia, meaning severely low platelet count. And a few things are at play here. Hantavirus damages endothelial cells, meaning the endothelial tissue that creates the inside of blood vessels becomes compromised. This affects the body's ability to regulate blood clots and causes consumptive platelet coagulation, aka the body is using platelets faster than it is making them. Now, after surgery, LC's body had essentially used up all of its clotting factors, and those are essential proteins produced by the liver that create blood clots. But she had used up all of those clotting factors and could not stop bleeding. And we see this manifested in the development of the petechia, the purpura, and the hematuria. Those were the rashes that she developed that are essentially blood underneath the skin. Thankfully, this issue responded to treatment of heparin. Here are some of the results of Elsie's labs that were conducted 4 days post-op. We see the low albumin, which is a marker of malnutrition. We see the high bun creatinine ratio, as well as the high creatinine clearance, indicating impaired renal function, most likely a combination of hantavirus and that history of acute pancreatitis. Her blood work indicates her body is extremely depleted, severe malnutrition, that thrombocytopenia, as well as indications that many of her organs are taking on damage from her hypermetabolic state. Here we have the PES statement, which is evident protein energy malnutrition related to small bowel obstruction secondary to escherichia, diarrhea, impaired absorption from bowel resection, as evidenced by 16-pound weight loss over 3 months, BMI of 17.4, and multiple nutritional deficiencies documented in labs. When Elsie was first admitted to the hospital, she was put on total parenteral nutrition, completely bypassing her compromised GI tract. But after surgery and regaining her bowel function, she was immediately put on enteral nutrition. She was put on Promote without fiber. And this was because Promote is high in protein to support her wound healing and recovery from critical illness. It also lacks fiber, which is appropriate for reducing GI motility while recovering from surgery. It's also suitable for lactose intolerance, and as Elsie is a vegan, we do not want to introduce any foods that might be triggering, and we also want to honor Elsie's personal dietary needs. Promote also has MCTs, which are friendly on her recovering bowels as they don't require any pancreatic enzymes to be absorbed. Elsie's nutritional needs were calculated via the Aspen guidelines, and that was about 1.5 liters of Promote every 24 hours via continuous infusion, and that was shown to support all of her nutritional requirements, except water, which did require an additional flush of 195 milliliters 3 times a day between feedings. Okay, now let's talk about some of the nutrition concerns for Elsie moving forward. She has had her entire duodenum removed, which is where iron, calcium, zinc, folate, and fat-soluble vitamins are absorbed. It's also where CCK and secretin are released, which are crucial for fat absorption and bile and digestive enzyme secretion. And that bile secretion is also key for fat absorption. Her proximal jejunum was removed, and this is a major site of macronutrient absorption, meaning Elsie now has impaired digestion of carbohydrates, amino acids, and water-soluble vitamins. Finally, she previously had a resection of her terminal ileum, meaning decreased B12 absorption, also fat-soluble vitamin absorption, and increased risk of oxalate kidney stones. Now, this is of particular importance because as a vegan, Elsie consumes a higher than average amount of oxalates because they are found in vegetables, certain vegetables. In normal functioning, oxalates bind to calcium and are excreted. But if fat is being malabsorbed, it has a preference for binding to calcium instead, leaving those oxalates to be absorbed and processed by the kidneys, therefore raising the risk of kidney stones. To monitor her diet moving forward, Elsie should adapt eating habits that follow a short bowel syndrome diet. These include eating small, more frequent meals in order to spread out the nutrient absorption and also to ensure that things aren't being forced too quickly through her smaller her smaller small intestine. She should strive to incorporate high quality sources of each macronutrient into her meal. Caveat though, she should avoid high fat and high insoluble fiber foods initially, as well as kind of a permanent limitation on like fatty fried foods, as well as sugary foods, as well as alcohol and stimulants such as coffee. She should aim for high protein or vegan sources of protein, such as tofu, tempeh, legumes, maybe a vegan protein powder, and also to prioritize soluble fibers over insoluble. So your soluble fiber is going to be like peeled fruit, nut butters, oatmeal. So eat those over insoluble fibers, which are like whole grains, bran, and whole nuts. It's also recommended to use a oral rehydration solution, ORS, to help manage fluid and electrolyte management. LC can buy those, or she can make her own, which often include a mixture of sugar, salt, and maybe some additional flavorings. She should also separate her food and drink consumption. This helps with symptoms of diarrhea. Avoid caffeine, alcohol, sugar alcohols, so sorbitol, mannitol, xylitol. And also to chew her food very thoroughly. And it is also helpful in that same vein to break down food, like mashing it, cutting it up into small pieces, that kind of thing. So Elsie also needs micronutrient supplementation because of, all of the parts of her small bowel that have been removed and all of the interactions or lack of interactions that she has now. So she definitely needs a B12 supplementation, which the intramuscular injection is maybe going to be her best bet, or a high dose sublingual, but her oral absorption is unreliable due to that terminal ileum resection. So vitamin D recommended 6,000 IU weekly for 8 weeks. And that is because a daily supplementation, so that should be 6,000 IU daily and then for 8 weeks, and then 1,000 to 2,000 IU a day for maintenance. And this is because when she's taking it every day, it's going to just increase the absorption rate, similar to why we want LC to have small, frequent meals 5 to 6 times a day. All right. And then once she's testing, she should get a full lab panel, first of all, to get a baseline of where she's at, and then retest like every 2 or 3 months until she has a solid baseline and she knows that her supplements are being absorbed and she's able to maintain homeostasis. All right, so she should also supplement with some iron. That's going to help. Essentially, she developed anemia with all of her low blood counts. So some iron to help bring those up. She should be supplementing with some calcium, calcium citrate preferred. And then also very necessary is fat-soluble vitamins. That's going to be A, D, E, and K. And those are because the sites of fat-soluble vitamin absorption in the duodenum and the ileum are compromised. And then finally, zinc, magnesium, and folate. Those are also going to be important, and she should monitor those with her labs just to make sure that her levels are where they should be. All right, summary and conclusions. So here we again will review our PES diagnosis, as well as the enteral nutrition prescription, the surgical impact of her small bowel removal, and then the discharge plan. So the summary of this whole case is LC's compounding issues of hantavirus and valley fever put her in an extremely hypermetabolic state, and the ascaresis meant that even the food she was ingesting was not fueling her properly. By initiating TPN followed by enteral nutrition via PEG tube, she received desperately needed nutrients. After removal of the Ascaris bezoar and bowel recovery, EN was started ASAP. Elsie had 199 centimeters of her small bowel removed, including the entire duodenum, 100 centimeters of proximal jejunum, and about 79 centimeters of terminal ileum from a previous surgery. Her extreme catabolic state culminated in disseminated intravascular coagulation, which was treated successfully with heparin. She was just discharged 1 month later and will undergo a bowel transplant at Cleveland Clinic in the future. Well, thank you for being part of this presentation, and I hope that you gained something from it. Thank you.